old man came to the general hospital with complaints of nausea, dry mouth and pain to chew food. The patient works as a construction worker and a heavy smoker for 10 years. In the gingival region of teeth 45-46, it appears that it is a reddish ulcer that forms a reddish color, is brittle and bleeds easily. Diagnostic procedure. Physical examination. Clinical features in these cases are exophytic, cauliflower, reddish ulcer, and lump. The radiographic image is interpreted as an indistinct edge image, a finger-like pattern, a sunburst image, and invasiveness to a large area. Biopsy. A biopsy is a mandatory procedure performed on patients with suspected carcinoma, including SC. Biopsy is a small sampling network and sent to the lab for examined with a microscope HPA. Dysplastic and atypia cells with hyperchromation in several horn pearl formations, based on a wider class, is quite good distinguished. Clinically, squamous cell carcinoma is seen as 1. Leukoplakia, white patches, erythroplakia, red patches, erythroleukoplakia, combination of red and white patches. 2. Exophytic growths, superficial lesions, may be cauliflower or papillary, and bleed easily. Ulcers with a size of 1 to 2 cm, mostly red or without white components, smooth. 3. There are extensive lesions on the dorsum of the tongue which are hyperkeratotic and have a rough surface. 4. Characteristics of carcinoma lesions are red and covered by crusts due to hyposalivation. Cell cancer (OSCC) is a multi-step process involving the accumulation of multiple genetic alterations modulated by genetic predisposition and environmental influences such as tobacco and alcohol use, chronic inflammation, and viral infections. The resulting anomalies can increase the production of growth factors and the number of cell surface receptors, and/or increase transcription or intracellular messenger factor levels. These changes can, in turn, cause a loss of tumor suppressor activity and give rise to a phenotype capable of increasing cellular proliferation, weakening cell cohesion, and causing local infiltration and metastasis. 7. Bad oral hygiene relationship against OSCC. Oral cavity with poor oral hygiene can cause opportunistic infection. Some of the bacteria that play a role, such as Candida albicans and Porphyromonas gingivalis. Candida albicans in immunocompromised individuals can form nitrosamines, that can cause oral cancer. Porphyromonas gingivalis can activate metalloproteinase promatrix and T-cell apoptosis, thus helps in formation of oral cancer. Nicotine can cause changes in blood vessel, where capillaries dilate. This results in increased infiltration of inflammatory agents leading to loss of collagen and gingival attachment which cause loose teeth. The risk factor of oral non-infection disease, one of them is smoking. Smoking contains tar that caused oxidative changes on oral cavity. This leads to increasing of free radicals. Free radicals causing damage to cells such as denaturation and gene mutation. Nicotine component on oral cavity causing the decrease of immune system. Because of that, PMN level, CD4, CD8 and IgA and Ig on saliva also decreasing.
Tobacco smoke contains more than 60 carcinogens including polycyclic aromatic hydrocarbons and nitrosamines. Tobacco-specific nitrosamines such as 4-methylnitrosamine 1-butanone, NNK, and N-nitrosamine NNN, which are carcinogens in tobacco that have been shown to increase the risk of cancer development by forming DNA.
Based on the main examination and supporting examinations, as well as risk factors such as smoking, genetics, and poor oral hygiene, the diagnosis of this case is oral squamous cell carcinoma.